Marvin Goldfried is a distinguished professor of psychology at Stony Brook University, where he helped to develop the graduate program in clinical psychology. He's the co-founder of the Society for the Exploration of Psychotherapy Integration. Alan Francis is a professor of psychiatry and chair emeritus at Duke, and was chair of the DSM-IV task force. Marvin describes the evolution of his psychotherapy orientation as psychodynamic, behavioral, CBT, and eventually integrative. He practices, teaches, and supervises what works clinically using direct and indirect evidence base. Alan describes his approach to psychotherapy as whatever works, or no one size fits all. He was trained and taught at the Columbia University Psychoanalytic Center, but remains equally interested in brief, supportive, cognitive, behavioral, interpersonal, and family therapies. Please enjoy this week's episode.
Good morning and welcome to Talking Therapy. I am Marvin Goldfried, and I am here with my long-term friend and colleague.
Hey, Marvin, Al Francis.
Notice I didn't say my old friend. I don't know quite how to phrase it. It's my old friend, well, my old friend, my long-term friend.
We're both.
Yeah. I don't want to make you feel too badly because that's, in fact, the topic for today's discussion. Patients come into therapy to feel good. Sometimes it doesn't work, and sometimes they get worse. So when do they get worse, and why do they get worse? Now, you said you have a lot of thoughts on this.
I think maybe the first thing we should discuss is how often does this happen? And there are a number of papers trying to put a number on it. I think it's really almost a futile effort because it's very hard to have a reliable way of determining a patient actually getting worse. That's hard enough. And then secondly, it's impossible to say whether they've gotten worse because of the therapy or they would have gotten worse anyway.
Right.
But my sense is that overall, it's probably somewhere between 5 and 10% of patients may actually be harmed by therapy. And I think that number is appreciable enough so we have to pay a lot of attention to it, and we need to study the causes of it and try to reduce that number. On the other hand, we should realize that people are much less likely to get harmed by therapy than they are by medication. The rate of harm from medication would be much higher, and the complications much worse. And so I always recommend when it's a choice of therapy or medication, which it often is for people who are mildly or moderately disturbed, I always recommend therapy first.
Yeah.
Because I think therapy is less toxic than medication. And only in those situations where the therapy doesn't seem to be working after a month or two would I begin medication.
Do you have any sense of how prevalent that strategy is with a contemporary crew of psychiatrists, where they say, I think therapy should be the first line of treatment and medication the second?
I would guess it's vanishingly rare.
Yeah.
I think partly because at this point, most psychiatrists only see patients after they've gone through filters, where the idea is, oh, we're sending this person to the psychiatrist for medication. That less and less of psychiatrists doing the initial evaluations. Usually when you get to a psychiatrist, because people think that you're going to get medication when you see the psychiatrist.
You know, the whole issue of prevalence of patients getting worse. I know that the whole topic of the adverse effects of therapy dates back about over 50 years. And I remember people writing about it in the past, in the 70s. And then it seems to have reemerged, but there was a lull of several decades when nobody was talking about this. Is that your impression?
Yep. But then in the last 10 or 15 years, it's become more and more of a topic, which I felt good about in one way and not so good about in another. It's good to be making this a topic, and that's why we're discussing it today, because we want to reduce the rate at which people get worse in therapy, and the only way you can do that is by studying it, thinking about it, and trying to develop means of reducing the risk. On the other hand, I was afraid that people would then get afraid of therapy. that as true as it is that some people get worse in therapy, it's equally true that medications are often a much riskier alternative. And when the two are equivalently desirable at the beginning, seemingly equivalently desirable, more and more people should be filtered to therapy. We shouldn't scare them off.
And do you have any sense of why there was this, pardon the expression, latency period of several decades when we said nothing, the field said nothing about this?
Yeah, I think that there was an important need to legitimize psychotherapy. And this was not just in the US, it's across the world. And that many of the therapy studies had the beneficial effect of showing positive gains that led governments and insurance companies to provide compensation for therapy, which previously hadn't been provided. And I think in that atmosphere, there may have been concern that if we also point out their risks, we may not become legitimized for payments.
Yeah.
And patients wouldn't have the opportunity to be in treatment.
Yeah. So the decade of the several decades of the clinical trial, see how good it is, see how good it is, see how good it is, was the message.
Yeah. And it's hard to study. I mean, I think that the studies that are done recently on harms in psychotherapy are usually not funded. It's people who are interested in the topic and do their best out of their own resources to do the studies. That it's very difficult technically to design a study that won't have fatal flaws, that will try to determine the rate and severity of harm and treatment for the reasons I mentioned before. It's hard to define harm, and it's even harder to find the causality of harm exclusively attributed to the treatment.
Right, and ethically, you can't randomly assign patients to good and bad therapists, if that's a factor. I know you were saying a little bit earlier, before we actually started the podcast, that you think one of the factors is that there are some therapists that are just bad therapists.
Yeah, I think the really important point here is not to blame the patients. I think the reflex tendency when treatments aren't going well, the reflex tendency on the part of many therapists and even supervisors is to think, oh, what's wrong with this patient that the treatment's not working? I think when a treatment's not working, it's incumbent on everyone to look at the patient-therapist match, the patient technique match, think about whether the therapist could be and should be doing something different, whether there's something about the therapist. The last thing in the world that someone should be doing is blaming the patient for this, saying, oh, they're a difficult patient or they're a non-compliant patient. It's their fault the treatment's not working. It's their fault that they're getting worse, not to blame the victim.
Isn't that to some extent built into certain theories like resistance?
Yeah, I think the idea of resistance was I think that the concept has merit. The naming of it as resistance and seeing it as a patient problem creates this illusion that when things are going badly, we can assume it's because the patient isn't doing his or her job that we're doing perfectly well.
Yeah.
There are certain patients who create great difficulties in therapy, but I think that the way of seeing this is we have to be doing a different kind of therapy with them, not necessarily that they're bad patients.
Well, I once had a therapist who was very psychodynamic, very psychoanalytic. He actually sat behind me. And during one session, he fell asleep. I turned around and he was sleeping. And I woke him up and commented on that. And he said, well, when you say something that's interesting, I'll pay attention. Talk about blaming the therapist. That was, the therapy didn't continue after that.
And the problem is that you were a strong enough person to realize how absurd that comment was. Many patients get trapped in therapies, become dependent on the therapist, and even when absurd things happen, remain in the treatment that's not good for them.
Yeah. I like the word trapped in therapy because that's exactly what I was thinking, even before you said it. We're starting to think so much alike, I'm getting worried, but that's okay. I'd like your thoughts.
I don't think we're starting to think alike. I think the reason we're doing the podcast is
it's because, some people want us to argue more, but You know, what's
Self-selection.
But yeah, the whole notion of you're in therapy, and I've been in some other therapies where and I knew about therapy. I was a therapist, and I just put up with stuff that was crap. It was really crap because, well, I was in therapy, and I felt this is, even though I knew intellectually, and eventually I got out of it. But there is that feeling of, well, maybe this is the way it's supposed to be. Maybe I'm not seeing something.
There was a literature that showed that first impressions in therapy are very important in predicting ultimate outcome, and that the quality of the relationship established after 3 or 5 sessions would be very predictive of whether the person got better or didn't get better in the treatment, or got worse in the treatment. And I think this is very important. It's something that I recommend that unfortunately is very hard to do practically in the world, that people not just see a therapist and go into treatment with them. In the best of all possible worlds, it's better to go into consultative visits with 3 therapists, 4 therapists, and pick the one that makes the most sense. That if you expend the resources at the beginning to ensure a good patient-therapist match, you're much more likely to have a good outcome in the long term. And it may actually be cost-effective not to rush into therapy with someone who you feel forced to see, who you really don't think is right for you. You spend weeks, months, maybe years with a person who doesn't really click with your needs, with your personality. And having a good match at the beginning is going to be predictive of whether you're going to have a good result at the end. And it's worth the investment at the beginning. You don't buy a car by going into a showroom and picking out the first car on the floor and saying, I'll buy that one. You don't buy a house by looking at one house and saying, oh, that's my house of the future. It would be good to allow, as a routine, for the matchup to be relatively flexible at the beginning. And when I ran an outpatient clinic, we did it precisely that way.
So I have a question. I'm really curious as to what your thoughts are, because I don't think there's an easy answer. And my question is, how's the consumer to know that not that the car is bad or faulty, or that the house is not a good prospect, but how are they to know that it's not a good match?
No easy answer, because the matches are so idiosyncratic. You can't study this because we have one way. I'll give you a way of one interesting point, and I'll get to the question.
Okay.
We did a study in which patients who complained about their treatment could, in a no-fault way, switch to other therapists. So we had the attitude, if a patient's complaining about the therapist, we're not going to blame the patient. We're not going to blame the therapist. We're just going to have an easy switch. We studied 75 patients who wanted out, who we gave a new therapist to. And in all but about 5 cases, the patients were happy, or happier at least, with the second therapist than they had been with the first. And we looked at whether there were particular therapists who tended to displease everyone, and there weren't. It turned out that a therapist who was terrible for one patient was terrific for the next. And a patient who felt completely misunderstood by the first therapist felt understood by the second. That a lot of it had to do with the matching rather than inherent characteristics of either the therapist or the patient. And I think empirically, there's no study that will ever show this, but empirically, it's not something that you're very good at predicting in advance. A lot of times I've referred people to a therapist, sure it was going to be a great match, and it exploded quickly. Other times I've been dubious about the match, and it turned out to be wonderful. And that's why I recommend to people, whenever possible, not to settle for the first person you see. You see several people and pick the one that matches you the best.
That's good advice. So, but it's interesting. You're not saying it should be based on, or the decision on the part of the patient that this is not working. should not be based on the theory of the orientation of the therapist, the experience, the reputation, but more a subjective feeling of this person doesn't get me.
Yeah. And I don't get him.
I don't get it. Even though, and that's just from talking. This is prior to any intervention, you know? So you don't know what the intervention or the orientation necessarily is. It's just that there's no chemistry.
Well, chemistry is intervention. The way a person, the way a person smiles, the way the first questions are asked, the way a person nods their head, the sense of, I like this place, I like this person, I can talk to this person. These are interventions, even though they're not in manuals.
Well, I don't know that, they may or may not be relevant interventions. If somebody comes because they have poor work habits or poor study habits, the intervention is not whether you like the person, whether the person understands you, but rather to learn better habits.
I think it's both. I think that we talk about the interventions as if they can exist outside the context of the interpersonal relationship. So I think the interpersonal relationship will rarely by itself be curative. Sometimes yes, but rarely. Usually it's the relationship plus the technical interventions. And I don't think you can take the two apart. You can have someone who's a great technician, but if they can't form human relationships with the patients aren't going to really benefit from the brilliance of the way they intervene. And on the other hand, you can have people who are terrific with people, but may not understand the specific technical needs of that particular patient. So I think the two are wedded.
But how do you account for somebody reading a self-help book where there is no understanding therapist and the information they get helps them?
I think that's true for almost everyone. That I think reading good self-help books that apply to the individual, if they're thoughtful about themselves, can be very helpful.
Yeah.
Often they're not enough, partly because the personal relationship creates a better opportunity for corrective emotional experience, partly because many people won't really understand what's in the book as it applies to them. It's too general. So I'm all for self-help if it's done in a useful way with the right materials and with a very thoughtful patient. And some patients do better with books than they do with people. So some patients who might be resistant to having an insight, if delivered in a therapy relationship, may get it aha from a book and may be able to change more. People who need to have a lot of independence and self-controlling their environment often will be able to get something if they've earned it through their own work. They may not accept it if they hear it from a therapist.
I think that there's a theme I want to underscore, and that is sometimes people enter therapy and for whatever reason, the constitutional limitations, the early onset of their problems, the severity of their life stresses, whatever it is, they enter therapy and therapy doesn't help. And now we're talking about how it could do harm. And they see themselves not only as having problems that needed therapy, but they see themselves as a failure, as a patient.
Yeah, I think one of the great innovations of cognitive therapy is the willingness to put yourself as a therapist in the position of being criticized by your patient. So many cognitive therapists will at the end of the day, how did this go for you? Did this make sense? Was I doing my job okay? Was there anything I could have done differently that would have been more helpful to you? Rather than assume that it's the patient's fault the session didn't achieve goals, rather than ignore the fact that the patient might have a completely different view of the session than you do, and that you really need the feedback to understand how they're feeling, and to reduce the patient's sense of responsibility if things aren't going well. It's very important the way you're putting it, that if the patient feels it's my fault at the end of something that's not working, that's not an opening towards changing the therapy relationship in a way that will make it more collaborative and more specifically directed to what that patient needs.
Well, do you feel that certain psychoanalytic therapists have that built into their orientation?
Yeah, and I think it's a real problem to always assume in a reflex way that when things are difficult in the session, when the patient's angry, when the patient is sullen, when the patient is withdrawn, that this is transference, that they're bringing into the session the experiences of their past, and that it has nothing to do with your behavior as a therapist. I think that leads to terrible distortions in the treatment. It gives the therapist a free ride, they're not investigating their own behaviors. And I think very often when a patient is angry at a therapist, it's not necessarily because they were angry at their parent or that they're bringing a current conflict into the room with the therapist, because the therapist has done something dumb.
Right.
The concept of transference is essential and valuable. It should be part of everyone's thinking, including cognitive behavior therapists, because it exists. But it shouldn't be an excuse for ignoring the therapist's own contribution in the here and now, in the room, in the patient's feelings.
It's being blinded by theory.
Yeah.
Blinded by that. I once came.
And it's comfortable. Oh, the patient thinks I'm doing something wrong. It must be because they were angry at their parent. I couldn't possibly do anything that would make a patient angry.
Right. The patient is never right and the therapist is never wrong.
Exactly.
Yeah. No, I once gave a presentation at a conference. I think the title roughly was Therapeutic Schemas, to see or not to see. And it was the role of theoretical schemas, to see or not to see. And it was the role of theory in distorting what goes on in therapy.
Tell us more. That sounds brilliant.
Yeah, well, I once saw a patient who was in many years of analysis, and he was gay, but reluctant to acknowledge this, and had been married. But his identity was primarily gay. And the analyst said that he was a latent heterosexual. And the goal of therapy was to get him to move developmentally into heterosexuality, because that's what theory says. I'll give you another example.
My first patient, my first long-term outpatient in 1967 was gay. And my supervisor wanted me to analyze his gayness so he could be straight again, or be straight. And I just didn't do it. I just couldn't do it. I felt it was wrong. And I just wound up not listening to the supervisor at all and doing what seemed right for the patient. But yeah, if someone has a theory that's completely wrong and it's blind to what the patient needs and wants, that's going to lead to harmful treatment for the patient.
Let me give you a really graphic illustration. Okay? And then we'll definitely have to continue this in another podcast. It's fascinating. Paul Wachtel, colleague who, as you well know, is interested in breaking down the barriers across orientations. Well, he had some graduate students who were interested in broadening their horizons and said, let's have a little case conference. I'll bring some students, you bring some students, come over to my apartment, we'll sit around, we'll drink coffee, and we'll talk about cases. So we did this, and one of my graduate students, who I was supervising in a case in the clinic, presented a case of a young woman who had been traumatized and was suffering from PTSD and had lots of fears and anxiety and was very close to her mother. But she was very afraid that something might happen to her mother. Okay? Was that not terribly surprising, right? Because she has been traumatized. So one of the psychodynamic students of Paul Wachtel's said, I think she's angry at her mother. And I said, well, why? Why do you think that? She's close to her mother. Well, I think she's angry at her mother, and it's manifesting itself. The derivative is that she is worried about her mother, but she's really angry. And I said, but where is that in the clinical material? And she said, well, it's a feeling I have. And I base my interventions based on my intuition. and my blood began to boil. And it's like, well, what do I say? I want to be gentle here, but I said, I think maybe your therapeutic plan is based more on theory than on the clinical case. And she said, no, it's intuition. And fortunately, Paul Wachtel stepped in and said, I think Marv is right.
Yeah, I think it's two things that can interfere with a therapist's ability to see things through the eyes of the patient in a way that will be harmful to the patient. One is theory, but also it's the therapist's own personal experiences. The therapist brings their own transferences, their own psychological defenses. And if that woman had that kind of problem with her mother, she's going to assume, the therapist may assume, the patient is having that kind of problem. So it's a combination of the therapist's countertransference, the therapist bringing into the session their own experiences and their own personal hangups, and the fact that theory may also blind them.
There's another element that's in there somewhere. I'm not quite sure where, but it's relevant. The absence of any knowledge about the characteristics of people who've been traumatized. If you don't know basic psychopathology and know what some of the symptomatologies are for certain kinds of clinical problems, and you're basing your intervention on theory rather than on knowledge of the case,
Great.
That's a whole other thing about clinical training that we'll get into one of these days in a podcast.
So that's three things so far you brought up. One is that you can be blinded by theory.
Yes.
Second is that you can be blinded by your own psychological reactions to not see the patients as different.
Right.
And the third is ignorance of psychopathology or ignorance of life experience that would allow you to put yourself in the patient's place.
What a nice therapeutic summary. You should be a therapist. Let's continue this. This is good. I like it.
I have possible suggestions that we continue this in maybe 2 further podcasts. One would be to discuss matchup issues.
Okay.
How do we get difficult matchup issues in terms of both the personal matchup and also the technique to patient matchup?
Okay.
The next might be to discuss those patients who have difficulty with psychotherapy, why they have difficulty, and how we can tailor the psychotherapy to them rather than coming in with our own inflexible, we do this for everyone, one-size-fits-all approach.
Sounds like a good plan.
Keep us busy.
Okay. Happy holidays.
You too.
And we'll talk.
I always love it, Marvin.
Stay safe. So do I.
Pleasure for me.
Bye-bye.
Bye-bye.